This conference will now be recorded.
Start చేసాం. Good afternoon, everyone. Am I audible?
Yes, ma'am.
Okay, fine. Good afternoon. Myself, Dr. Bhavya Sindhu, Assistant Professor in Dermatology. Okay, we'll be discussing about pediatric dermatosis today. As rightly said by Dena, like fruit, children are sweetest just before they turn bad. The importance of this slogan is like you need to diagnose things before they turn bad. Okay. This topic is very important not only in terms of dermatology, but you come across these cases when you see children in pediatric department. So I'll be giving you basic outline or gist of everything rather than going into fine details of everything so that you can identify the diseases. So what are the diseases we are talking about, or this list of things? But the commonest problem in pediatric age group is infections and infestations, which comprise about 54.5%. So infections and infestations are common things in pediatric population. Second to infections are dermatitis and eczematous conditions, which are allergic conditions. And these are the other things, few of which we'll discuss about today. Coming to classification, this is again the same classification in terms of infections, infestations one side, which are contagious from one person to another, and eczema and allergic conditions on the other side. Next, infections. What are the different types of infections we see in children commonly? Those are bacterial infections, viral and fungal infections. Among the viral, we'll be discussing about warts, molluscum contagiosum, and many other things. First, we'll discuss about viral infections. Coming to viral infections, these are the picture here shows multiple papules which have a verrucous surface. If you see closely, these are called warts. Wart is a common colloquial term, whereas the scientific term is verruca. Why are they called verruca? Because they have a verrucous surface, irregular verrucous warty surface is there. So this is called verruca vulgaris. What are warts caused by? Warts are caused by human papilloma virus. You can see warts are of different types, like common warts which are usually seen in hands, all over anywhere in the body. Plantar warts which are seen on the feet. Genital warts in genitalia. The mode of transmission is different for different types of warts. Genital warts, it's mainly sexual mode of transmission, whereas these normal warts, they get transmitted when the virus gets inoculated onto a traumatized skin surface. So when the virus enters a traumatized, even micro trauma is okay for the HPV to get inoculated. So once it gets inoculated, it multiplies in the epidermis and forms a papule kind of thing. So warts are caused by human papilloma virus, which present as multiple verrucous papules. They can be there anywhere in the body and they spread with contact. If anyone touches the parent of child, if the parent touches these warts, and they get spread to even to their hands. Usually children acquire warts from their parents rather than vice versa. So what is the treatment of warts? Even if you don't treat, they get resolved by themselves, but it takes some time, like few months or so. But we need to treat. The reason is because they keep on spreading, being it an infection, so it keeps on spreading from one place to another if you don't treat it. What are the treatment options if at all you treat? Like we can excise them with cautery. We can use cryotherapy where we spray liquid nitrogen onto the wart. We can actually excise the warts, and we also have many oral treatments for warts. You can also leave it as such so that it resolves by itself. But it spreads to other parts and also to other people. The reason to treat the patient. Okay, next towards is molluscum contagiosum. What is molluscum contagiosum caused by? Molluscum contagiosum is caused by pox virus, mollusky pox virus. So what are the lesions like? Lesions, you can see a papule here. It actually looks like a vesicle, but it's not a vesicle papule. It is a papule. Molluscum contagiosum presents like multiple dome-shaped waxy papules, which actually look like vesicles, but they're not vesicles. So it presents as multiple dome-shaped papules, translucent waxy papules with central umbilication. Umbilication means a depression in the center. So this is a very common infection in children which you need to know about. So because many people, even your neighbors, are they bring their everyone thinks that MBBS graduate knows everything about any branch, but we actually know something about every branch. So this is that something and which you need to know. So this is MC. It presents as papule, commonly, very commonly seen in children, usually on exposed sites, because this virus gets inoculated into microtraumatized skin. So exposed sites presents as papule, which is translucent waxy with central umbilication. What is the method of treatment? Similar to what, you can leave it as such so that it will resolve. Our own immunity can resolve the MC lesion, but it also can spread just like warts. It also can spread to other people and also involve other parts of the body. So we need to treat it. What are the treatment options for this is, we can actually extirpate the lesion. Extirpation is something like we remove the body, molluscum body, with a needle. So that is called extirpation. We can extirpate the lesion. We can apply KOH on the potassium hydroxide on the lesion. This is called chemical cautery. So there are different treatment options. You need to counsel the parent that it's nothing but a small viral infection, but you have to take treatment for it. Okay, this is molluscum contagiosum. The same thing, you can see the papule which is shiny. This is MC. Next one, you can just follow the pictures and my lecture rather than reading the slides. This is a child who presented with vesicles in a particular fashion. What can be the diagnosis? Okay, the diagnosis is herpes zoster. Herpes zoster is also called shingles. As you all know that herpes zoster is reactivation of varicella zoster virus, which was dormant in the ganglion. Like the children, this herpes zoster infected children, they will have an episode of varicella in their past. After that, the varicella zoster virus gets dormant in the ganglia, and then when there is stress or any kind of immunosuppression, then the virus gets activated and it presents itself as a dermatomal rash. Like what will the rash look like? Rash is vesicles and erythema with pain. They complain more of pain rather than itching. This is classical herpes zoster. Whenever you see a rash linearly along a dermatome, suspect herpes zoster. Another differential diagnosis for it can be an insect bite reaction. Insects usually, when they crawl linearly, there appears an irritant contact dermatitis kind of reaction, which also has vesicles linearly. So the linear vesicles, there are only two differential diagnoses in children, two common differential diagnoses in children, which is insect bite reaction and herpes. If it has intense pain, then it is herpes zoster. If it has only little itching and sudden onset, even zoster is sudden onset, so you need to weigh those things and arrive at a diagnosis. What you have to tell to patients is attend a doctor immediately, because we need to start an oral antiretroviral therapy. What's the dose of acyclovir in herpes zoster is a standard and important question for you. In adults, it's 800 mg 5 times a day, which is one answer you should know about definitely. So 800 mg 5 times a day is the dose of acyclovir in herpes zoster. It's 20 mg per kg body weight per dose in children. It's okay. So this is the rash where you see vesicles in dermatomal distribution. This is another, it's not a common entity, but it's a common question for your entrance. So I have included this. It is eczema herpeticum. Eczema is means allergy. Herpeticum is herpes infection. So what is eczema herpeticum? In atopic, it usually occurs in atopic individuals. When there is eczema or atopy, if at all the infection occurs, it gets generalized. So in all the lesions of eczema, the infection gets proliferated and all. It presents as disseminated infection. So the question which usually asked is, an atopic child has presented with this kind of lesions, eczematous, erythematous, vesicles all over the body. What's your diagnosis? It's eczema herpeticum. Not only herpes, but other viruses like Coxsackie virus, pox virus can also cause this kind of rash in allergic individuals, but eczema herpeticum is little more common. Next is chickenpox. Chickenpox is a must. It's a very important question for you in terms of multiple choice questions. Like chickenpox is caused by varicella zoster, as you all know, and varicella zoster is a type of herpes simplex virus. Okay, how does it present? Chickenpox, these all viral infections like measles, varicella, these all have a prodrome. Prodrome usually has fever, headache, malaise, sore throat and all, followed by rash. The rash is the one that differentiates mainly from other things. Like in chickenpox, the rash will be, it initially starts with papule. It starts as a macule, papule, vesicle, and then forms a crust. You people may think that for everything these people will say the same, but in chickenpox you can actually see the stages of evolution. Like you can see few macules, erythematous macules, you can see few papules, you can see vesicles and few crusts also. So this is called polymorphic appearance. You see many types of lesions at the same time. Polymorphic and pleomorphic lesions are seen. See, you can see macules, papules, vesicles, and crusts. When will the patient not be infective to other ones? Like till till the lesions crust and the crust fall off, patient is infective. So vesicles, that vesicular fluid has abundant virus, and so whenever there are vesicles or crusts, the patients need to be isolated. Till all the crusts fall off, you have to isolate the patient, because this is a question that is commonly asked by your neighbors. Like, we have got chicken pox, what should we do? Should we bath or shouldn't we? So this is a common question that we frequently encounter. The answer to this is, you have to take bath, but don't use soaps, don't use those neem leaves, don't use Dettol and all. We have to bath only with lukewarm water, not too hot water. And there will be itching, so we have to give antihistamines, but you have to tell the patient not to meddle those lesions, because all the chickenpox lesions usually they come down without leaving scars. They leave scars only when we meddle them with our hands, only when they get secondarily infected, because they don't take bath, that will get infected and form scars. Because the scratch, that will get infected and form scars. So these are very, very important things. So in acute phase you have only the rash, but when they leave scars, it will be a lifelong thing, right? So prevention is better. This counseling is very important. And how will you treat chickenpox? Chickenpox also same as zoster treatment. And you also know that immunization schedule has chickenpox vaccine also included in it, which is Varilix. Next is measles. Measles is measles has a prodrome of three C's, as you have studied in your SPM: cough, conjunctivitis, and coryza. Uh, After that, a rash appears. Rash, as you all know, it's post-auricular. It starts as a post-auricular rash, which later generalizes, and there will be blotchy erythema. It's called maculopapular rash, which is not common these days because of vaccine. It's basically important for your theory part. Like, you will get MCQs on this. The question will be about Koplik spots usually. These are they are erythematous spots on the buccal mucosa. These are called Koplik spots. There will be other complications like you all know, lung infections and the middle ear infections. Fifth disease, this is also important in term of question. Fifth disease are called erythema infectiosum, where you have slapped cheek appearance. You have to know these three terms. Fifth disease or erythema infectiosum caused and it presents a slapped cheek appearance. Coming to pityriasis rosea. Pityriasis rosea is a dermatologic condition basically rather than viral infection because its etiology is not completely known. It's just thought to be a reaction pattern secondary to viral infection, but it's not yet proved. But it's very common in children, so you have to know about it. It presents as erythematous patches with scaling at the periphery. So first patch is called herald patch. Initially, the first patch will be a large one and it will be on lower abdomen or thighs. It will be a larger one. It's called herald patch. After that, many patches will appear, but they'll be in small size and they'll be there on back in fir tree or Christmas tree kind of distribution. The reason why I'm repeating things are these are the terms you need to know and these are what are asked in your questions. I know that most of you may not be interested in dermatology, but all of you should know dermatology because you will get questions in it to enter into any branch you want. Okay. So PR has annular patches with peripheral scales and the pattern of this pattern. Next is cold sore. Cold sore is also called normal herpes. Herpes labialis is called cold sore. These things can also occur in adults, but the reason I'm telling is when it comes in a pediatric patient, you have to diagnose it because that's important. Counseling plays a major role in pediatric population than adults because parents will be scared of everything and anything. So this is herpes, also called cold sore. It presents as multiple vesicles, grouped vesicles. So herpes is different, herpes zoster is different. Herpes zoster is caused by varicella zoster virus, which is also a group of herpes simplex virus, but this cold sore or herpes labialis is caused by herpes simplex virus, HSV1. That is HSV type 3. Varicella zoster virus is 3, right? This is by HSV1. So varicella zoster either presents as chickenpox or zoster in linear distribution. But this herpes labialis, it presents as vesicles grouped. It may not be segmental. They are grouped. That's all. They need not be localized to a segment. They are just grouped vesicles. Zoster will be a painful thing, whereas this is not at all painful. They complain of little itching, little pain, but it's not so painful condition. Acyclovir is the drug of choice, and acyclovir, the dose in adults is only 400 mg TID. Whereas for zoster, you need a lot of 800 mg, 5 times a day is the dose of acyclovir in zoster. So don't get confused between these two. Zoster is different, simplex is different. Zoster is caused by varicella virus. Simplex is caused by HSV1. Zoster needs higher dose of acyclovir. Simplex needs lesser dose. Okay, and even both have herpes simplex has recurrences. So coming to bacterial infections, let me just give a small gist about viral infections you already studied. HPV causes warts, which are papules with warty surface. MC virus causes molluscum contagiosum, which are translucent papules which look like vesicles with a dome-shaped and central umbilication. Pityriasis rosea, it has a viral etiology, but it's not sure. It presents as herald patch first, and then annular lesion with peripheral scales. And then what are the infections we studied about? Varicella, chickenpox, herpes zoster, herpes simplex. Okay. The reason why I'm repeating is at least you hear once so that it gets into your mind. Okay, then there should be some use in listening to the class, right? So, okay, impetigo. The commonest infection is impetigo. Impetigo is usually seen in children, and impetigo can be caused by staph and staphylococcus. In the term used is honey colored crust, as you can see in the first photograph. They are honey colored crust in impetigo. Impetigo is of two varieties, bullous and non-bullous impetigo. In bullous impetigo, you see the annular lesions. See, initially there will be a bulla, but that will be very temporary. Like it ruptures very easily, forming an annular erosion. So this is bullet sympatigo, and retupamolin, the second one. Mupirocin is T-backed, and retupamolin is another important drug, which is a recent one and which will be asked in entrance. Okay. This is bullous impetigo. Next is folliculitis. Folliculitis is hair follicle infection. Folliculitis is usually caused by Staph aureus. Staph aureus is, as you all know, it is resident flora also. Staph epidermidis is present in skin, and Staph aureus is a resident flora in our nasal cavities. When it infects the hair follicle, it presents as folliculitis. Folliculitis is, as you can see in that picture, it's a small pustule. When it goes deep, when the infection goes deep, it forms a nodule and surrounding peripheral erythema, little induration. It's called furuncle. So the second picture is, you can see the central pustule with peripheral erythema, edema, and there will be brittle induration. It's called furuncle. The common term is boil, furuncle or boils. Okay. This, when there are multiple furuncles side by side, they fuse and form multiple sinuses. It's called carbuncle. Carbuncles are very commonly seen in diabetics. So this is folliculitis. Leave about this MRSA. And next is pitted keratolysis. Pitted keratolysis. You can see pits on soles. This is the classical picture of pitted keratolysis, which is caused by micrococcus. It's usually seen in those who dip their feet very frequently into water and those who sweat a lot. So hyperhidrosis is the term used for more sweating, increased sweating. So in those, it's seen in people who wear shoes a lot of time because they sweat a lot. So what do you see? You see multiple thickened plantar skin with multiple pits. It's called pitted keratolysis. It's a bacterial infection, so you need to treat it with antibiotics. It's usually caused by micrococcus, and erythromycin is better antibiotic of choice. And what we have to do is treat the associated conditions also, like treat hyperhidrosis. They have many treatments for hyperhidrosis, and we also give general measures like avoid excessive sweating, wear cotton socks, these kind of things, wear open slippers kind of things rather than shoes. See, you can see pits better, you can appreciate pits better in this picture. Next is Pseudomonas folliculitis, also called hot tub folliculitis. See, this is also not a common condition, but it is a kind of fancy question. Hot tub folliculitis is caused by Pseudomonas. That is the only thing you have to know, and it is most commonly seen in people who use swimming pools. It's also called swimming pool folliculitis. Next, coming to fungal infections. Like, what are the bacterial infections we discussed? Folliculitis, furuncles, impetigo. These are very common things and you have to know about this. Okay. Pitted keratolysis is not so common. Pseudomonas folliculitis. Coming to fungal infections. The fungal infections everyone knows is tinea or ringworm. As you all know, ringworm is not worm. Just because it's annular, it's called ringworm. What is ringworm caused by? Ringworm is caused by dermatophytes. It's a dermatophytic infection. You all know that dermatophyte, it feeds on our skin, our dead skin, epidermis, not dermis. Dermatophytes never ever go deep into dermis until unless there are secondary things which you need not know. Dermatophytes, they feed on this keratin, which is present in very superficial layers of skin. So these are superficial fungal infections. This tinea, also called dermatophytosis, also called ringworm, is a superficial fungal infection. Okay. Next, what are the different terms used for the dermatophytic infections at different sites? When it occurs in a body, you call it corporis. When it occurs in head, you call it capitis. On face, it's called fasciae. On hands, what is it called? Manum. On hands, it's called manum. On legs, it's called pedis. Tinea pedis, tinea manum. On when it infects nails, it's called tinea unguum. When it infects the intertriginous areas, groins, it's called cruris. When it infects body, it's corporis. Head, it's capitis. You all knows these terms, and I think you have learned these in your microbiology. See, this is Tinea fasciae. When it is seen in face of males with the terminal hair, it's called tinea barbae. Like when an adult male comes to you with a tinea lesion on his chin, which is hair bearing area, you call it tinea barbae. When a female patient presents with the same kind of lesion on chin, you call it tinea fasciae only. Only in hair bearing area, you call it barbae in males. Okay. What is the class and what does the classical lesion look like? A classical tinea lesion is annular with peripheral activity. The disease activity is at the periphery, whereas our immunity, it clears the disease from the center. So it presents as an annular lesion with peripheral papules, sometimes vesicles when the infecting fungus is zoonotic one. So peripheral papules or vesicles, annular lesion with central clearing. Okay, this is the classical tinea infection. Okay, it is very pruritic, though it's very superficial infection. It has a lot of effect on quality of life. Most of you know this condition because it's very common. What do we treat it with? We treat it with topical and oral antifungals. Topical because the fungus is very superficial, but only topical is not at all. Though book says that if it's less than 10% of body surface area, only topical treatment is okay. It's not actually true. Practically, we have to give oral antifungals in each and every case of tinea. And okay, this is a small spotter kind of thing where this is below eyelid, and what you can see is erythema with red lines over it, right? So what are this? This is actually, these red lines are vessels, the superficial dilated vessels, which are called telangiectasias. So this is the result of applying topical steroid. Clotrimazole is antifungal and betamethasone is potent, very potent steroid, which dermatologists don't give on face. They never give it on face. Right, like our RMPs and all, the only drug they know is steroid, be it oral, be it topical. They give it left and right, and the end result is patients come to us complaining about it. See, you may think that it is just erythema and few lines over face, but the thing is, it's permanent. That there is steroid induced atrophy. The result of that atrophy is that visibility of these vessels. So it's steroid induced atrophy with telangiectasia, which is irreversible. So when giving steroid on face, we people also should be vigilant. See, steroid atrophy with telangiectasia due to use of steroids. So don't use topical potent steroids. On the current IADVL theme is, IADVL is Indian Association of Dermatologists, Venerologists and Leprologists. Fight steroid abuse. Okay, steroid should be used, not abused. Okay, even when you visit your relative's house or so, you can see this cream being used left and right in each and every house, but they don't know the sequences about this. Being doctors, you should educate them, like never use combination creams unless prescribed by a dermatologist. Okay, what is this? This is tinea incognito. We use the word incognito in dermatology when anything is altered by the application of steroid. So there is an initial tinea lesion and the patient has applied steroid. What happens when you apply steroid? Steroid is, it decreases the inflammation. So there won't be papules, there won't be vesicles, lesion will be little clear, that erythema will be reduced. It also has little antipruritic effect. There won't be itching because there is no inflammation, there are no inflammatory cells, there is no itching. So patient will be happy. Appearance wise lesion has decreased, and symptomatic wise also lesion has it's improved. So patient will be very happy. Fungus will be even more happy because we are just giving steroid, we are not giving any antifungal, right? It can proliferate happily. So both will be happy for some point of, but at some point of time they'll come back. They'll come saying that it has spread to the entire body and they have applied steroid for long duration, like 3 or 4 months. We can actually appreciate striae, wide striae in patients using topical steroids for this kind of infection. So never ever use topical steroid for fungal infections because fungus is happy, very happy, and it proliferates, and there is no inflammation, there is no immunity acting upon the lesion. So it silently proliferates. If it proliferates evidently, we'll treat it. Patient will be happy that he's improving, but fine, but he's not actually improving. So this is called tinea incognito. Incognito, as I said, it's the term used when we use a topical steroid. The same term can be used for scabies also. We call it scabies incognito. Coming to tinea, the mode of infection is the direct contact, fomites. This is all what you know. What we see in KOH mount or hyphae. You can see slender hyphae here in the second picture. Coming to tinea capitis, which is also important. Tinea capitis has 4 varieties. Capitis, as I said, it's head infection of tinea. It has 4 varieties, mainly gray patch, black dot, Kirion, and Favus. Each of them is a potential question. Believe me, gray patch is where you see multiple grayish patches. Okay, multiple grayish patches with hair loss, little hair loss or grayish hair. Next is black dot. You can see in the picture like there are multiple black dots in the patch. Next is carrion. Carrion is the second picture where you can see a boggy inflammatory swelling. So gray patch is grayish patch. Okay. Black dot is multiple black dots. Why did these dots occur? It's because the fungus has entered into the hair and broken the hair. It broke the hair. So the hair, so fungus cannot enter into deeper into the hair which is live. It can only enter into the upper parts of hair which is dead, which has keratin in it. So the upper part of hair is all destroyed, hair gets broken and it appears as black dots for us. So it's called black dot tinea. Carrion is a boggy inflammatory swelling. It occurs when with the zoonotic type of dermatophytes, where you can see studded, it's boggy inflammatory swelling studded with pustules, where you have to give an antibiotic along with antifungal. Okay. This is a very common condition. We actually go to schools and screen for tinea capitis with Uts lamp. These are also pictures of tinea capitis. There will be broken hair, black dots. What do you treat it with? It definitely requires an oral antifungal. Okay, oral antifungal along with the topical antifungal shampoos can be given to some extent just to decrease the shed and decrease the transmission. And sometimes tinea can be beautiful too. This is called tinea concentricum. Next is yeast diaper rash. Yeast is what I want to tell is candidial diaper rash is common condition. Diaper dermatitis is different. Any rash in the diaper area has very many differential diagnoses. It can be due to irritant contact dermatitis due to the ammonia present in urine, feces, and all. It can be seborrheic dermatitis. It can be a Langerhans histiocytosis. rash in diaper area, it can be due to acrodermatitis enteropathica. So there are many differential diagnoses in for a rash in diaper area. We here are discussing about candidial diaper rash. How does it present? It presents as erythema, pustules in the diaper area, and intertriginous regions you have the intertrigo. That is like as it is very whitish discharge kind of thing in the intertriginous areas. You can see it in the picture along with satellite lesions. Satellite lesion is the characteristic feature of candida, where you see the tiny small pustules around the lesion, out of the lesion, away from the lesion. You can appreciate this, it in this picture, where you can see the multiple pustules out of the lesion in the lower abdomen part. Okay, this is characteristic candidial infection, where you see satellite lesion. So we treat it with antifungals, topical and oral antifungals. The sports related infections are not actually important for you. Coming to infestations, okay, I'll just give an overview of infestations because we are running out of time. I'll discuss the other things in the next class. This is so I heard that you people have questions, mainly clinical questions for your entrance. So this is one such kind of question where you have what do you see, the soles are involved with pustules and all. So what is the differential? It's basically one, it's basically the patient is an infant. So what is the diagnosis? Diagnosis is scabies. Scabies, as you all know, you might have heard about it very many times. So I'll just give an overview. It's called by Sarcoptes scabies. It's also called itch mite. You have itching. The patient has itching usually in the night. Why is it in the nights? It's because the itch mite has a favorable temperature. We sleep at a comfortable temperature, right? That temperature is also comfortable for the itch mite. So it comes out and moves in the nights. That is the reason we have itching more in the night. Also in the mornings we'll be preoccupied by something else, whereas in the nights our brain is free, so we feel that itching actually. Both are the reasons for that. And where do you see papules, vesicles and all? You see them in the circle of Hebra. So what is that circle of Hebra? It's in between interdigital spaces, ulnars of wrist, ulnars of forearm, ulnar aspect of arm, axillae, and nipple, areola, umbilicus, and genitalia. This is called circle of Hebra. Okay, these are the classical sites of scabies, whereas the only exception is in infants, that is below 1 year. You see lesions on palms and soles, vesicles and pustules on palms and soles. In this upper picture you can also appreciate vesicles. Okay, vesicles in palms and soles, itching, family history, all these point towards scabies. So you all know that there are very many types of scabies, like nodular scabies, scabies in clean animal scabies. Okay, fine. And we can actually demonstrate this scabitic mite by just removing a burrow and placing it on glass slide by adding KOH. Normal adult will have, infected adult will have only less than 10 mites, but it is very itchy condition. The pictures show different types of scabies. Upper one is a normal scabies where web spaces are involved. Second one is nodular scabies where there are nodules in the scrotum. Third one is scabies in infancy where palms and soles show vesicles. What is the treatment of scabies? For scabies, we usually advise the patient to apply permethrin, which is commonly used nowadays. There are many other drugs. Permethrin overnight application, we ask them to apply it below neck. We need to leave the face because scabies mite doesn't affect face, because face has sebum and sebum is antifungal. So below neck, apply permethrin, entire tube for one person, not just apply as much, just like a light application. You shouldn't do that. One tube has 30 grams tube, 30 grams tube for an adult. Entire tube must be done in a single night. Okay, so apply it, keep it overnight and wash it next day. And then we have to advise them to wash all their clothes and all which they have used for the past week, and all family members must be treated. These are all things you know and you need to know. And okay, fine, we can deal with this in the next class. So these are the things we are discussed about: bacterial infections, viral infections, a little about infestations. Okay, CR, please send me the attendance.
Ma'am.
If you have any doubts, you can ask. CR, send me the attendance. And
Yes, ma'am.
okay, we'll discuss the remaining part of PPT in our next class.